At Grifols, we've pioneered the research of blood and the therapeutic properties of plasma since 1909. Thanks to donors, we develop plasma-derived medicines that help millions of patients globally. We also offer a comprehensive portfolio of solutions designed to enhance transfusional safety, as well as tools and services that help healthcare professionals efficiently deliver expert medical care. A legacy of more than a century of innovation empowers us to design in-house technological solutions and build state-of-the-art manufacturing facilities recognized widely for their excellence. Since the beginning, ethical leadership, social commitment, and a passion for science have paved our journey. As we continue to grow, we work to find new solutions to the healthcare challenges of the 21st century and remain committed to our mission of improving the health and well-being of people around the world. At Grifols, we've pioneered the research of blood and the therapeutic properties of plasma since 1909. Thanks to donors, we develop plasma-derived medicines that help millions of patients globally. We also offer a comprehensive portfolio of solutions designed to enhance transfusional safety, as well as tools and services that help healthcare professionals efficiently deliver expert medical care. A legacy of more than a century of innovation empowers us to design in-house technological solutions and build state-of-the-art manufacturing facilities recognized widely for their excellence. Since the beginning, ethical leadership, social commitment, and a passion for science have paved our journey. As we continue to grow, we work to find new solutions to the healthcare challenges of the 21st century and remain committed to our mission of improving the health and well-being of people around the world. At Grifols, we've pioneered the research of blood and the therapeutic properties of plasma since 1909. Thanks to donors, we develop plasma-derived medicines that help millions of patients globally. We also offer a comprehensive portfolio of solutions designed to enhance transfusional safety, as well as tools and services that help healthcare professionals efficiently deliver expert medical care. legacy of more than a century of innovation empowers us to design in-house technological solutions and build state-of-the-art manufacturing facilities recognized widely for their excellence. Since the beginning, ethical leadership, social commitment, and a passion for science have paved our journey. As we continue to grow, we work to find new solutions to the healthcare challenges of the 21st century and remain committed to our mission of improving the health and well-being of people around the world. At Grifols, we've pioneered the research of blood and the therapeutic properties of plasma since 1909. Thanks to donors, we develop plasma-derived medicines that help millions of patients globally. We also offer a comprehensive portfolio of solutions designed to enhance transfusional safety, as well as tools and services that help healthcare professionals efficiently deliver expert medical care. A legacy of more than a century of innovation empowers us to design in-house technological solutions and build state-of-the-art manufacturing facilities recognized widely for their excellence. Since the beginning, ethical leadership, social commitment, and a passion for science have paved our journey. As we continue to grow, we work to find new solutions to the healthcare challenges of the 21st century and remain committed to our mission of improving the health and well-being of people around the world.
Yeah, you may start in 3, 2, 1. Please go ahead, sir.
Well, good evening, friends. Today our guest speaker is Dr. Rajiv Pruthi from Mayo Clinic, Rochester. He is going to lecture on updates on Willebrand disease. This webinar is brought to you by Mumbai Hematology Group. It is supported by Grifols and managed by Perfect Square. I thank Mr. Anish Sapre and their team from Grifols for supporting our academic activities. Yash Kalpesh and the team from Perfect Square for managing them flawlessly. The Executive Committee of Mumbai Hematology Group to give me this free hand to organize these webinars. And of course, our guest speaker, Dr. Rajiv Pruthi, who every 4 to 6 months has been with us conducting these wonderful webinars. All our discussants were themselves eminent hematologists or pediatric hemato-oncologists, and you participants for sparing your Saturday evening if you are from India, and morning or afternoon from the rest of the world. Our website is www.mhgindia.com. We have an extremely important meeting coming up towards the last week of January, which is an in-person meeting based on essence of ASH, which was held in December last year, that is just a month ago, as well as the 46th annual conference of Mumbai Hematology Group. It's a 4-day long meeting, and you can see the agenda at this website, www.mhgindia.com, and you can register for the meet also from that website. Tomorrow morning, we have our own Dr. Nidhi Jain from Zydus Hospital, Ahmedabad, speaking to us on CMV infection, all that a hematologist should know. Our discussants, as you know, that they are very, very important people. They are going to take you through the discussion with our guest speaker. Their names have been displayed here alphabetically. We have Dr. Akanksha Garg from Jodhpur, Dr. Akshaya Mangloi Goyal from Varanasi, Dr. Anita Mahajan from Delhi, Dr. Ankit Rayani from Ahmedabad, Dr. Asha Shah from Mumbai, Dr. Bijita Datta from Kolkata, Dr. Chandrakala S. from Mumbai, Dr. Hamza Yusuf Dalal from Mumbai, Dr. Radhika KK from Hyderabad, Dr. Manoj Toshniwal from Aurangabad, Dr. Mona Vijayaran from Lucknow, Dr. Nilesh Vasekar from Nashik, Dr. Prashanta Bhatt from Mangaluru, Dr. Rajat Jain from Pune, Dr. Rucha Patil from Mumbai, Colonel Dr. S. Venkatesan from Pune, Dr. S.P. Verma from Lucknow, and Dr. Tejaswini Gudibande from Bangalore. It's my pleasure to introduce Dr. Rajiv Prathi to the very, very young guys who are listening today. The seniors don't require any introduction. He has been our friend, colleague, and he's been speaking to us. He's been in Mumbai multiple times for our CMEs and conferences. And during this pandemic, he has enriched us in the field of thrombosis and hemostasis. He's associate professor at Mayo Medical School, Rochester. He's consultant, Department of Internal Medicine, Hematology, Department of Lab Medicine and Pathology. He's director, Comprehensive Hemophilia Center, co-director, Special Coagulation Molecular Hematopathology Labs. He was born in Nairobi, Kenya. He did his medical school in India. Then he did his residency in internal medicine in Milwaukee, followed by a fellowship in hematology, oncology, molecular biology, and genetic research at Mayo Clinic. His clinical and research interests include lab diagnosis and management of bleeding and thrombotic disorders. I request him today to teach us about von Willebrand disease, and I'll stop here. Over to you, Dr. Raju.
Thank you very much, Dr. Agrawal and the Mumbai Hematology Group for the privilege of presenting today. I'm going to share my screen. Okay. Hopefully everyone can see my screen.
Yes.
Okay. So today I'll be presenting an update in von Willebrand disease, and we'll be discussing different aspects of the diagnosis and then formulate, discuss different approaches to formulating a treatment strategy for patients with von Willebrand disease. We'll be talking mainly about congenital von Willebrand disease, and we'll touch on acquired von Willebrand syndrome towards the end. As I was preparing this talk, I prepared this talk last year as well. Around that time, the national societies came up with some guidelines on von Willebrand disease. So it was very fortuitous. And so a lot of what I'll be presenting is guidelines and the evidence for those guidelines. As a background, von Willebrand disease is a very common bleeding disorder. It's due to a deficiency or defective von Willebrand factor, and that's congenital is the most common, and acquired von Willebrand syndrome is very uncommon and not very well recognized, and we'll talk a little bit more about that. So if you look at the earlier studies that were laboratory-based studies among school kids or apparently healthy population, the lab-based prevalence of congenital von Willebrand disease varied by study from 0.01% to a high of 1% of the population. Now that is actually a very high prevalence. And this is based on screening lab tests, so von Willebrand factor antigen and activity assays. However, if you look at that cohort of patients with diagnosed von Willebrand disease, only about 1% of those patients have symptomatic bleeding. So the prevalence is likely quite low. And in one primary care setting, the study that was done, the prevalence was found to be 1 per 1,000. So you can see the different prevalences, and the prevalence in the primary care setting, it's very important because that's relevant to who you would test in the primary care setting versus somebody that's referred to the hematologist to evaluate. So we're going to talk about, as I said, congenital and then touch on acquired von Willebrand syndrome. Just a couple of words on the pathophysiology. Von Willebrand factor is synthesized in megakaryocytes in the marrow and in the vascular endothelial cells. What happens there then is, so circulating platelets have von Willebrand factor, but from the endothelial cells, it's either secreted into plasma or it's secreted, well, I should say, and into the subendothelial tissue, which is amazing, a fascinating experiment of nature that is exactly where von Willebrand factor is needed. So if you sustain vascular injury, you have von Willebrand factor in the subendothelial tissue to encourage platelet adhesion. In the platelets, it's stored in the Weibel palate bodies, and in the platelets, sorry, in the endothelial cells, it's in the WP bodies, and in platelets, it's in the platelet alpha granules. The main function for von Willebrand factor is platelet adhesion and aggregation. And the secondary hemostasis, it's important because von Willebrand factor is a carrier protein for factor VIII. An emerging recognition of a very important function of the high molecular weight fraction of von Willebrand factor is that they have an anti-angiogenic property. And I'll elaborate a little more when we come to the clinical aspect of von Willebrand factor. So here is a cartoon of the endothelium, the subendothelial tissue, subendothelial collagen, and then you have platelets. So when you sustain vascular injury, platelets are normally bumping into the endothelium, rolling, and if the endothelium is intact, they simply move on. Now this occurs at a very high shear. But if you have a defect in the endothelium, you expose collagen, you expose von Willebrand factor, and the one receptor that's important for platelet adhesion is the glycoprotein 1b9 receptor. These are constitutively active receptors. So when this platelet is rolling on the endothelium and comes into contact with this defect, right away von Willebrand factor binds to this receptor. Remember that it's a high shear, so the platelet is still rolling on, but von Willebrand factor is such a powerful protein, it's like lassoing a horse, and then it pulls on this receptor and that activates the platelet. Once it activates the platelets, other receptors get activated, particularly the 2b3A receptor. And once that's activated, fibrinogen binds to it, a little bit of von Willebrand factor binds to it as well, and that attracts other platelets, and hence you have your platelet aggregation phenomenon. The 1b9 receptor, congenital disorders of 1b9 receptor are Bernard-Soulier syndrome. And for the 2b3A receptor defects, it's Glanzmann's thrombasthenia. So clinical presentation of congenital von Willebrand it's classically described as mucocutaneous. So mucosal, epistaxis, oral GI bleed, and cutaneous, bruising, ecchymosis, whatever terms you describe that as. Particularly in women, and I think it's very important to keep in mind, women present at an earlier age than men because of heavy menstrual bleeding at menarche. Now, one exception is severe type 3 von Willebrand, and because there's such a severe deficiency of von Willebrand factor, they behave like severe hemophilia. Remember, von Willebrand factor is a carrier protein for factor VIII, and when you have severe deficiency of von Willebrand factor, your factor VIII is also severely deficient. So these patients can bleed. In addition to mucocutaneous bleeding, they also experience soft tissue and joint hemorrhage. Once in a while, every few years, we get referred a patient who is misdiagnosed as severe hemophilia A. We do the full panel of tests, and we find, lo and behold, he actually has severe type 3 von Willebrand disease. So one of the take-home messages here is, if you see a low factor VIII, don't interpret that in isolation. You always need to ask the question, what's the von Willebrand factor level? And therefore, you can at least exclude von Willebrand disease and manage the patient as hemophilia. So age at diagnosis depends on whether or not there's a family history. And if there's a family history, usually they're diagnosed at an earlier age during childhood or adolescence. But I tell you, over the years that I've been practicing, bleeding disorders medicine, every year, once a year, we'll get a patient who in their 50s or 60s who was not diagnosed. They've lived with a lifelong bleeding tendency. You would assume they would have been evaluated appropriately, but never assume that. Always do the workup yourself. And many a time they refer to our hemophilia center before surgery because the patient has had bleeding, and lo and behold, they have von Willebrand disease. So in the pediatric population, testing is done shortly after birth. If there's no known family history, sometimes you test after spontaneous bleeding or after surgical related bleeding, but hopefully they are referred to you before the surgeon operates to make sure you're not missing a bleeding disorder. In women, of course, as I mentioned, because of the high frequency of heavy menstrual bleeding, they're diagnosed at an earlier age, most of them anyway. So the sequence that we will talk about is how the guidelines presented the different questions. So a group of experts from International Society Thrombosis Hemostasis, from World Federation Hemophilia, and National Hemophilia Foundation in the US got together and addressed in a very logical fashion, what's the clinical question, what's the evidence for our recommendation? And, spoiler alert, there's not a whole lot of recommendations for a lot of, evidence for a lot of the recommendations, but that's the best we can do. Now, who do you test? Bleeding symptoms are very common in the general population. So that really poses a challenge in the selection of patients on who you should test, because testing is not cheap. And for a lot of patients, that could be a lot of out-of-pocket expense. If you look at the incidence of heavy menstrual bleeding in women, depending on the study, 20 to 44% have heavy menstrual bleeding. Incidence of epistaxis is also pretty high. And so over the years, the world's experts sat and said, okay, can we develop a validated, or can we develop a questionnaire that we can validate that gives you a high probability of having a bleeding disorder? And can we implement that into clinical practice? In 2005, the Italians got together and developed a very, very comprehensive bleeding questionnaire that took about 40 minutes to administer. And they scored each bleeding symptom on a scale of 0 to 3. Then the Europeans as a group got together and developed another questionnaire, but this was very time consuming, so they condensed it. They developed a pediatric questionnaire. And finally, the International Society on Thrombosis Hemostasis got together and said, let's consolidate all of this and let's work on a very short questionnaire that has a good validity. So this is what the International Society on Thrombosis Hemostasis endorses. And this has also been developed into a self-administered bleeding assessment tool. And so you can see this is the progression over the years. And if you can get this reference, it very nicely describes the evolution of bleeding questionnaires. And then you subject these questionnaires to sensitivity, specificity, positive and negative predictive values. In general, I'm going to say that positive predictive value is never perfect. The condensed one seems to be very good here in this study. But the negative predictive value, I think, has more value. So you can decide, okay, you don't have a high bleeding score, we don't need to test you. And so this is just a summary of the different sensitivities and specificities. So the ISTH endorsed the bleeding assessment tool, but please note that this tool was very specific for von Willebrand disease. It is being applied to other bleeding disorders like platelet disorders and just as a screening tool, but it's really thoroughly validated for von Willebrand disease. I'll show you the different questions, but ultimately the bleeding score for males is less than 4, for females less than 6. And the pediatric score, this is so complex, and I really feel for the pediatricians because these children have never been exposed to the different, surgical challenges or hemostatic challenges that adults have. So the threshold for testing is very low for the pediatric population. This is a screenshot of the different questions that are asked. For years, the coagulation groups across the world have been pontificating that, oh, the best initial test is the patient bleeding history. But then you have to take that a step further. Well, what do I ask? And what if the patient says I have epistaxis? What's considered significant? So that's the biggest impact this ISTH score has had. Epistaxis, then you score each presentation all the way up to needing transfusion. This is for dental extraction, menorrhagia, postpartum hemorrhage. If you go to this website, so bleeding score, CERTI, Netherlands, That's what I use in my practice. When I'm sitting with the patient, rather than sitting and writing this down, I just open up my web browser and I show the patient the screen, and they tell me, okay, I have heavy periods, but I've only changed. This is all I do is change my pad every 2 hours. So that scores a 1. And this tool actually gives you the final score at the very end. So once you've done your bleeding score assessment, so Tosetto provided the likelihood ratio of having von Willebrand disease. And you can see as the bleeding score rises, the likelihood ratio of having von Willebrand disease also rises. And if you have a bleeding score of 6, 7, 8, 9, or 10, the likelihood ratio goes up astronomically. And so you can really confidently test this group of patients for von Willebrand disease particularly, but frankly, you should also be looking for other bleeding disorders. Now, I'm going to throw in a caveat here. So Dr. Paula James, who wrote the chapter in the guidelines, one of the chapters, she was visiting Mayo, and I asked her, so, and Dr. James is the one that actually developed the ISTH bleeding assessment tool. I asked her, so in your clinic, you go through the bleeding assessment tool, and then do you actually tell patients, I'm not going to test you? She said, no, I test everybody. And I felt better because anyone that comes to our coagulation clinic, we test them because there's a couple of reasons. Most of them we need to undergo surgery, but some of them just want a peace of mind. Do I have anything serious? And if you can exclude any serious bleeding disorders, they feel satisfied. So I didn't feel so bad. Now the guidelines went through, it was an international collaborative effort, and they graded the recommendations according to some validated approaches. And this was published in the Blood accompanying sister manuscript, Blood Advances in 2021. I do believe this should be open online access. And then they rated the quality of evidence. So 4 circles high, all the way down to 1 circle, very low quality of evidence. So this was published last year. And here's how they approached it. The first question was, should you use, now the BAT stands for Bleeding Assessment Tool, should you use a bleeding assessment tool to screen for von Willebrand disease? And for patients, especially men and children, with a negative or normal bleeding assessment tool, do you not do testing? So should you use a tool, and if it's normal, should you not test? Now the recommendation was based on 2 stratifications. One was low probability of having von Willebrand versus intermediate to high probability. So here's how they approach this. Individuals who are seen by their primary care providers, the aggregate data suggests the prevalence of von Willebrand disease of about 3%. Some of the data I showed you earlier was 1%, so it varies by study. And here are the sensitivities and specificities of this 7 cohort studies. So what they recommended for the primary care provider, use a validated bleeding assessment tool and proceed with a blood test only for an abnormal bleeding assessment tool. Now, what I'm sharing here are the guidelines, but remember, guidelines are guidelines. And when you're sitting in front of the patient, you have to make that decision that are you going to test or not? And as I said, most people who get referred to the hematology clinics get tested, and I'll show you why. So individuals, I think I skipped a slide here. Here it is. So individuals who are referred to a hematologist for evaluation of bleeding symptom, the prevalence of von Willebrand disease jumps to 20%. It's already a selected population. So what they say here is, do not rely on the bleeding tool to decide if you're going to test or not. I mean, again, you can still do the bleeding assessment tool for you to understand the severity of their bleeding, but you should go ahead and do the testing. And I think most of our practitioners will be doing that. Individuals who have a much higher probability are those with a family history of von Willebrand disease. Here, the prevalence jumps to an approximate 50% prevalence. Again, they recommend against using the tool to decide to test, go ahead and test. And this does make the most sense. If you have one family member that's affected, there's a pretty high probability that you'll have other family members also affected. So the take-home message, who do you test? For low probability, screen with bleeding assessment tool, and at least the guidelines suggest you test only if abnormal. My recommendation is I think you should test just to make put the patient's mind at ease. For intermediate and high probability, go ahead and test. And as I said, the bottom line is most patients will refer to you. It'll be disappointing to turn them away that you're not going to test, but and then also remember there are a whole host of other bleeding disorders that have abnormal bleeding assessment tool or have borderline bleeding assessment scores. So moving on to the disease, it's categorized into quantitative and qualitative defects. So type 1 von Willebrand disease, it's autosomal dominant, but it has a variable penetrance. And the reduction in von Willebrand factor are mild and variable. There is one subtype called type 1C that is a very short von Willebrand factor survival. Sorry, that's a typographical error. That should be survival. Type 3, I mentioned, is the most severe, with this absent or severe reduction in von Willebrand factor levels, and they behave like severe von Willebrand disease. For the subtypes 2, you have the 2A, B, and M. Here, the von Willebrand factor activity is discordantly reduced compared to the antigen. So the mutation is on a platelet binding domain typically, or it could be on a collagen binding domain as well. And then the type 2N, sorry, there's a frame shift in my brackets here. The type 2 Normandy is a mutation in von Willebrand factor where factor VIII binds to von Willebrand factor protein. So they have a normal von Willebrand factor function, except factor VIII is not able to bind to the protein, and therefore factor VIII half-life or survival is shorter. And these patients are typically mistaken for having mild hemophilia A. And in one international survey, up to 5% of patients with mild hemophilia A actually had von Willebrand Normandy subtype. And so the testing is different here. You have to look for the binding assay or the genetic test. So once we're done with our von Willebrand factor assays, and our panel includes an activity assay, an antigen assay, and then also factor VIII, and then we run high molecular weight multimers to subtype the von Willebrand disease. Type 1 von Willebrand disease has normal distribution, but a mild reduction. But the new 2N, Normandy, and the 2M, and M stands for Milwaukee, also has normal distribution of the multimers. But the type 2A and B von Willebrand disease have a variable reduction in the high or intermediate sized plasma von Willebrand factor multimers. And of course, in type 3 von Willebrand, there are no multimers to look at. So it's pretty much a blank gel, except for the dye that runs out at the end. So you've decided you're going to test, you've done the test, and then you have patients that have either a mild or a moderate reduction in von Willebrand factor. So you have to keep in mind the factors that affect von Willebrand levels. The most talked about is the blood group effect. Blood group O von Willebrand disease, blood group O patients have a lower von Willebrand factor, average von Willebrand factor, than the non-O. And this is shown best on this next slide. You can see patients with blood group O have lower levels compared to the other blood groups. So you have to take that into context. However, currently it's not recommended to stratify the reference range by blood group. If you have a low level, you have a low level. There's two take-home messages from this slide. One is the fact that blood group O level individuals have lower average levels compared to the other blood groups. And the second is, look at the effect of age. With age, von Willebrand factor levels rise in all blood groups. So quite often we see a patient who was diagnosed with von Willebrand disease in their 20s. They have lowish levels, and then they come to you or refer to you when they're 60, 70, or 80, and now their levels are normal. So that's a natural phenomenon. And we struggle sometimes, okay, they were diagnosed, now do we undo the diagnosis? And if they have normal levels, at least my approach is quite practical. If they're going for a minor surgery, and their levels are normal, I don't supplement them with any factor or DDAVP. The other factors that influence von Willebrand levels, any stress situation, so steroids, stress, acute or chronic inflammation, and the one to remember in women is estrogen use and pregnancy. Because if you're testing individuals when they're pregnant, their levels may be normal. So we always emphasize that if you've been given the diagnosis, you're pregnant, somebody tested you when you were pregnant, you must repeat the testing after labor and delivery. So what assays do you do? I won't spend too much time on this because it's very complex. And because of the pleomorphic functions of von Willebrand factor, in other words, it has a variety of platelet binding, collagen binding, factor VIII binding, there are a variety of assays. I think uniformly, the easiest assay to think about is your antigenic assay. So it measures the amount of protein in plasma. The functional assays, there are a variety of functional assays on the market. There are those that have platelet binding assay, activity, which may be ristocetin dependent or independent. So you have the traditional long-standing platelet-based assays, the ristocetin cofactor assay. But with modern instrumentation, there are others that are showing up that basically are ristocetin dependent. So this is an antibody-based assay. Ristocetin independent assays are, again, antibody-based assays that bind to the GP1B. And then the one that the guidelines are recommending is the GP1B-M assay, which only recently has become available in the US. Then if you suspect a Normandy variant, you have a collagen binding assay or the Normandy factor VIII binding assay. So once you're done with one or more of these tests, and your local labs may have different assays or only one of these, and it's important for you to communicate with the lab director to find out what the performance characteristics are in the laboratory. Then the role of the multimers is only to subtype von Willebrand disease. So functional assessment, the original assay was the ristocetin cofactor activity assay, which was based on a washed platelet assay. We still have this assay, but it is so labor intensive. We also have an automated assay, but it's interesting, when the automated assay came out and we implemented that, we had a lot of our lab services a lot of reference lab clients. And it's quite amazing how many of them were just very focused that they wanted the ristocetin cofactor activity assay. Because back in 2008, the US guidelines said you have to do this assay, but there have been many more better assays that are out there now. So it's wise to switch. So in this assay, ristocetin binds to the 1B alpha receptor, which activates the platelet and it results in platelet aggregation. The problem with the ristocetin cofactor activity assay is that the coefficient of variation, it ranges. I mean, you can send the same sample to multiple different labs, and the spread of results you'll get is between 40 to 50%. And some will call it normal, some will call it abnormal when it should be normal. So, and the lower limit of detection really is not very low. It's between 10 to 20%. One unique racial aspect of this particular assay is that there's a polymorphism in the 1B receptor. And it's particularly prominent among Black Africans, where they have this one mutation, and that results in an in vitro lower estimation of the ristocetin cofactor activity. These patients don't have a bleeding disorder, though. It has no effect on in vivo platelet binding. So this is one, and if you in the US, we have a fairly large African American population, so we may be misdiagnosing a lot of patients with von Willebrand disease. I won't go into detail here, but this basically graphically describes the different assays that are out there, the ristocetin dependent and the ristocetin independent. The bottom line is it's better to have a ristocetin independent assay, so you're not relying on multiple different reagents. This is one that we have in our lab, and the guidelines are recommending this particular assay. But what's interesting, it's only recently got FDA approved in the US. But they're also recommending this one particular assay, the 1BR. So just take a look at this, talk to your lab directors to see what you have in your laboratories. The panel suggests newer assays over the ristocetin cofactor, which is what I mentioned, and they're recommending these two assays. But if you look at the level of evidence, it's sort of, wishy-washy. This is the performance characteristics of across multiple different studies. The sensitivity and specificity varies. Now, at one of the meetings, I did ask the question, why didn't you look at this particular assay? Why were there no recommendations? Because there are publications on this assay. And I didn't get a very good answer. Now, we have this assay in our lab, and it performs very well for the diagnosis. But anyway, the guidelines are coming up with this recommendation. Now, the caveats of the literature are that these studies were done to understand the assay and to classify von Willebrand disease patients, not to make a new diagnosis. And these were all case control study designs. So really, ideally, you would want to have a prospective study of patients being evaluated with bleeding symptoms, and you run multiple different assays and look to determine which is the most sensitive and specific. Those will be difficult studies to do. So coming to some more specific questions, one of the very controversial, just in the context of what I mentioned on the factors that influence von Willebrand factor levels, one of the questions that was posed was that patients with low von Willebrand factor levels, what's the diagnostic cutoff? Should it be less than 30? So when I'm using the terms interchangeably, so 30% is the same as 0.3 IU per ml, and 50% is the same as 0.5. So in our lab, we report it as in percentages. So what they recommended was, if you have a level of less than 30% or 0.3 IU per ml, regardless of whether they have bleeding symptoms or not, they get the diagnosis. But if you're between 30 and 50%, and 50% is a lower reference range in a lot of labs, only with abnormal bleeding, you get the diagnosis. Now, if you look at this and reflect on this a little bit, over the years, I've certainly seen patients with levels around 30 with no bleeding symptoms, and they were tested because of some minimal, maybe an episode of epistaxis or bruising. It's hard. I mean, they may not have bleeding symptoms, but practically speaking, if this patient needed to undergo surgery, I would be giving them factors. So regardless of bleeding, this is a very reasonable to give them the diagnosis. This is the more controversial one. If you have a level between 30 to 50%, and you would only give them diagnosis if they have abnormal bleeding. Now, if a patient who had 40% von Willebrand factor level and needed to undergo major surgery, it's a little risky if you didn't replace the von Willebrand factor. So personally, I always replace, because it's easier to replace and reduce the risk of bleeding compared to not replacing and putting the patient at risk for bleeding. So for the unique subtype of 1C, which is a shortened half-life, this is in this particular disorder, there's an increased clearance. And why is that important? Because when you replace von Willebrand factor in these patients, or you give DDAVP, generally these patients have mild bleeding and they have mild reduction in von Willebrand factor levels. But if you need to prep them for surgery, desmopressin is really a very cheap drug to use. It's important to know what their half-life is, because you might subject them to dental extraction, give them DDAVP, but within 4 hours, their levels come down, and then they might bleed. So it is important to do a trial, but there was this suggestion that you could use the propeptide. So the way von Willebrand factor is processed after its translation, there's a propeptide that's cleaved off. And there was a suggestion that you can use the propeptide to antigen ratio to make the diagnosis. And on average, the group decided don't use the propeptide, use the 1 and 4 hour post-desmopressin levels to demonstrate increased clearance. And that's important because, as I said, in the surgical setting, or even in women with heavy menstrual bleeding, if they have the 1C, just giving 1 dose of DDAVP may not be sufficient. You might need to give more doses, or in fact, use other interventions that we'll talk about. Then the other question that was posed was, when you have a type 2 von Willebrand, where the activity is disproportionately reduced compared to the antigen, what's the cutoff? Is it 0.5 or is it 0.7? You can look at the quality of evidence. There's not much evidence, but they suggest against 0.5, but to use the 0.7 cutoff. Why is this important? Is because if you have a type 2 von Willebrand, DDAVP might not work, and you probably want to use von Willebrand factor concentrate for surgical management, and hence the importance of the cutoff here. What about multimers? When should you do multimers? And should you be doing? There's literature looking at the collagen binding assay, and if it's reduced compared to the antigen, and the high molecular multimers are really important for collagen binding. So there was a suggestion that you could substitute the collagen binding for the multimers, and not much evidence for either approach. And so they do say that you can use either the multimer analysis or the collagen binding to make the diagnosis of type 2 von Willebrand. Now, why is this important? To be honest, there are not many centers that run the multimer. And there aren't many centers that run the collagen binding assay. So I guess what the guidelines are saying, that whatever you have access to, use it. They're both pretty reasonable. In Australia, Dr. Favallaro has done some very nice studies, and he's really validated his collagen binding assay, and his assay performs very well. And it's much less labor intensive compared to the multimer analysis. So in Australia, they rely completely on the collagen binding assay. And this is what the multimers look like, which I've shown you before. I won't go over it again. So, of course, emerging technologies, and we have more and more labs that are running von Willebrand factor gene analysis. My lab runs it as well. And the question they asked here was, if you're trying to distinguish 2A versus 2B, and I'll come to why that's important, should you use this particular, very difficult to do, called the ristocetin-induced platelet aggregation assay, or should you do the genetic test for von Willebrand 2B? Again, not many labs offer the RIPA. Our lab certainly doesn't. And what the panel suggested is you can use targeted genetic testing over the low-dose RIPA to diagnose 2B von Willebrand disease. So the phenotype of 2B is actually, the mutation is a gain of function mutation. So when you aggregate platelets using the patient's plasma, it just takes a very low dose of ristocetin at 0.6 milligram per DL to aggregate platelets, whereas people with 2A von Willebrand, they do not aggregate with the low dose RIPA. So anyway, they say do the genetic testing over the low dose RIPA, and you really need to validate this assay very well if you're going to use that. So what about the Normandy variant? Again, it's we're spending a lot of time on recommendations on type 2 von Willebrand, which is reasonable because those are the most difficult to distinguish. And the question here was, should you use a binding assay? Excuse me. Should you use a binding assay or targeted genetic sequencing to diagnose the Normandy variant? And they didn't have strong feelings on either. You could either use the genetic testing or the binding assay to make the diagnosis. For the binding assay, literally, there's only one company in the world that I'm aware of. Stago makes the kit for this. So that's what we use in our lab. There are other labs that have homebrew assays as well, which they've validated. So that's reasonable to do. One of the challenges is getting the sample, shipping it, freezing it, shipping it, and making sure it doesn't thaw before it gets to the laboratory. As opposed to genetic testing, you can just ship ambient sample of whole blood to the testing laboratory. And as long as it gets there within a week or two, that DNA should be good enough to use. So you can use either genetic testing or the binding assay if you have access to it. Okay, so what about management? We'll just talk about principles of management here and then go into detail. All patients should be educated. It's very important to provide, empower patients to understand their disease, provide them with written information. It's very important to refer them to hemophilia centers that are experts in managing bleeding disorders for long-term follow-up. So at least in the US, that's the push to get patients to these centers. Now, not every state has more than one center, so that's also a challenge. It's also important for the patients to wear a medical alert so that if they get into an accident, they're unconscious, they're wearing an identifier on their disease, so they're taken to the local emergency room. The physicians know what to do. And then, very important, this is a genetic disease, so testing of family members, whether they're symptomatic or asymptomatic, is also very important. It's important to make the diagnosis. Let's talk about specifics for hemostatic management. You can categorize agents for hemostasis into non-factor or factor replacement. The factor replacement is very easy. There are multiple different plasma-derived concentrates available. And if you don't have access to 1 Willebrand factor concentrate, cryoprecipitate is rich in 1 Willebrand factor, but because of the risk of infection, of course, it's advisable to go with a purified concentrate. There's only one recombinant product in the world, and so the two are available. The non-factor options, I touched on desmopressin or DDAVP, so I'll refer to it as DDAVP. There used to be an intranasal form, so this is intravenous or subcutaneous form. The intranasal form is called Stimate. It's currently off the market because of concentration variability in each lot, but hopefully it'll be back in a couple of years. And then there's oral agents such as epsilon aminocaproic acid, also known as Amicar, and then tranexamic acid as well. So these are antifibrinolytic agents. So how do we use these different agents? And at least most people approach this as it depends on what you're managing. So let's go into that. The advantage of desmopressin is low cost, definitely more widely available compared to 1 Willebrand factor concentrates, and the ability to administer intravenously, subcutaneously, or intranasally provides a distinct advantage. I want to emphasize that the intranasal formulation, this is a high concentration for 1 Willebrand disease. There is a low concentration of intranasal DDAVP that's used in pediatric population for bedwetting. So just to make sure that the right concentration is prescribed. Mechanism of action of desmopressin is it releases endogenous 1 Willebrand factor from the endothelial cells. Now, one of the weaknesses of DDAVP is that if you repeatedly administer DDAVP, you deplete your endothelial stores, and that results in tachyphylaxis. So you won't get as high a response to repeated administrations. When do you use it? It's very important before you clinically use it that you've documented a good hemostatic response to either the intranasal or the parenteral administered DDAVP. Then you can put that in there. We generate treatment guidelines for all of our patients. So you can actually provide them with a document, and if they are seen by physicians that are not experienced in bleeding disorders, patients can present that document, and then they can appropriately treat them. Side effects, most experience minor side effects. They're predominantly vasogenic, flushing, tachycardia, headaches. But some people experience even these, what we're calling minor side effects. Some people can't tolerate it, so they'll refuse to take DDAVP in the future. There's no question that there are serious side effects too. Repeated administration, DDAVP results in an antidiuretic effect. So repeated administration can result in fluid retention, and this may increase the risk of hyponatremia and seizures. There's a very small risk of thrombosis. Just the fact that you're raising von Willebrand factor levels, and in those with severe atherosclerosis, there's a theoretical risk of thrombosis. I've never actually experienced it in my patient population. And when do you use it? In minor bleeding and minor surgical procedures. And if it's with minor surgical procedures like a colonoscopy with polypectomy, you could combine that with tranexamic acid or epsilon aminocaproic acid. So that's when you would actually use it. So who should you do a trial in? So you've tested your patient, you found low levels, and they have suspected type 1 von Willebrand. I would say that anyone with mildly reduced levels, you should go ahead and do a DDAVP trial. So what we do is you administer the DDAVP, you check a 1 hour post level, and then you check a 4 hour post level because you want to measure the half-life. In selected type 2 subtypes, we still do the DDAVP trial, and I'll show you some data on some of our patients. Now, it is less useful in severe type 1. So if you have somebody with like levels of less than 30 or less than 20%, with normal distributed multimers, that's a more severe type 1. I would still probably do it, but it's probably less useful. There's no sense in doing a DDAVP trial in type 3 because they have no endogenous von Willebrand factor. In the type 2 von Willebrand, it's felt to be contraindicated because you're releasing an endogenous von Willebrand factor, and that's already a dysfunctional von Willebrand factor. It's got a gain of function mutation. So that results in thrombocytopenia. And so you're paradoxically reducing the platelet count and perhaps putting the patient at risk for bleeding. Now, in children less than 2 years of age, at least our pediatricians just don't do it because of the high risk of hyponatremia. So the typical dose intravenously is 0.3 mics per kilo. There is a subcutaneous formulation, which is more concentrated. Same, 0.3 mics per kilo subcutaneous dose. Now, it sounds easy to do this, but it depends on how your vials of DDAVP come. They come in glass vials. So when we wanted to try subcutaneous DDAVP, it comes in glass vials. So the pharmacists are saying that the patient will have to filter it to make sure no glass particles go in, and the volume that goes into each injection, they'll have to give themselves 2 injections. So there's some very practical issues. It sounds easy for me to say, yep, just use subcutaneously, but there are some very detailed aspects of actually executing that that get in the way. For Stymate, which is as I said, it's not on the market right now. Hopefully it'll come back. So if you have a low body weight patient, we prescribe 1 spray into 1 nostril only, and it delivers 150 micrograms. But if you have somebody with greater than 50, 1 spray into each nostril, so you're delivering a total of 300 micrograms. And one of the questions that's asked is, what's defined as a response? And in aggregate, after much discussion, the experts said, well, a complete response is defined as somebody that has a response to von Willebrand factor and factor VIII of up to greater than 50%, or higher, I should say. Partial responders are less than 50, but it goes up above baseline. And then there are non-responders that don't meet either criteria. I mean, I would say if somebody goes from 30 to 45%, that's still a good response. And that might be sufficient, maybe perhaps to use for heavy menstrual bleeding or maybe a dental extraction in conjunction with adjunctive agents. So this is some data looking at our patients. This is a patient I follow in the multiple different patients I follow in the Hemophilia Center, type 1 von Willebrand. And this is measurement of ristocetin cofactor activity from baseline pre-DDAVP, 1 hour post. And you can see the scale is not showing up, but a large number of them have a good response, but some of them don't. So that's the importance of doing a DDAVP trial. We have a group of type 2A and 2M von Willebrand patients, so we do DDAVP trials in them. And you can see some of them respond amazingly well. And you can see the scale on the left side here, and some of them just don't have a response. So there's one patient who was already pretty high as a baseline, didn't have a response at all. So it's worth doing the response, documenting it. Now, when these trials were done, we didn't do 4-hour post-infusion levels, so it's important to do that now to document the half-life. This slide is simply to show you that some investigators tried to correlate response to DDAVP with mutation status. So responders have mutations all over von Willebrand factor gene protein. Partial responders seem to be clustered in these domains. And then you have non-responders that are pretty specific regions where the mutations are predictive of non-response. Now, do you need to do gene testing just to know if the patient is going to respond? Probably not. It's still useful and important to go ahead and do the gene testing. The other thing on this slide is to show you the von Willebrand factor protein. It's got multiple different domains. It's a huge protein. And the complexity of this is the different domains, the functional domains, and hence the different assays that you would have to do, like, the collagen binding assay. Here's the factor VIII binding region. And then this region is important for multimerization. Von Willebrand factor also binds to heparin. So that's an interesting fact to know. All right, so with all that, I shared a little bit of data, and the experts took a look at, who do you need to, do a trial on. So they asked some questions, listed right here. Should you do a trial? Do you not do a trial and just give von Willebrand factor, or do you treat empirically? So the recommendation here is, for those in whom desmopressin is a valid treatment option, and that's predominantly type 1, and have a baseline of less than 30, that you should do a trial. Now, I don't know why they restricted to less than 30. I would say even if you have a level of 40 or 50, you should do a trial. And what they say is they recommend against empiric use of desmopressin in the absence of a desmopressin trial. So the bottom line is do a trial, except perhaps in type 3 and type 2B von Willebrand disease. A couple of mentions on women's health, which is very important. So first of all, heavy menstrual bleeding is very common, even in the general population. So there's the studies that were done were looking at, for women that present with heavy menstrual bleeding, what is the prevalence of von Willebrand disease? So between 5 to 20%, and between 5 to 36% in adolescents. So you have somebody presenting to your clinic with heavy menstrual bleeding. There's a high likelihood that they may have underlying von Willebrand disease. Now, if you look at it from the other side, if you have a cohort of patients with von Willebrand disease, what's the prevalence of heavy menstrual bleeding? And that varies too, from 30 to 100% by study. So the bottom line is heavy menstrual bleeding, it's important to rule out von Willebrand disease. And if you have von Willebrand disease, you can expect heavy menstrual bleeding is going to be a problem. I will say though, heavy menstrual bleeding is very difficult to assess. It's a very subjective thing. And one feature that we observe in our patients with women with von Willebrand disease is they have heavy menstrual bleeding, but then they say, well, my mother had it and my aunt had it, so it must run in our family. So they don't bother bringing it to their physician's attention. It's important that they bring it to the attention so you test for a bleeding disorder so you can help these women function in society. And that's the most important thing. So let's talk about what the guidelines came up with on heavy menstrual bleeding. Should you use tranexamic acid? Should you use hormonal therapy? And that certainly could be intrauterine devices or contraception, or should you use desmopressin? And they broke it up into women who do not wish to conceive versus women who do wish to conceive. So for those that do not wish to conceive, use either hormonal therapy or tranexamic acid, and they preferred those two over desmopressin. And I don't understand why they said that, because some women do very well with at least the intranasal form of desmopressin. And I didn't realize the extent of that until Stymate was taken off the market. And we had a number of adolescents and even adults call us and say, what do I do? I mean, desmopressin's worked for me for so long. And so we felt really bad for them. And we talked about alternatives. For women who wish to conceive, they suggest tranexamic acid over desmopressin. Now, there is low quality evidence, but I'll talk about what evidence there is. Occasionally, though, you'll have to have multiple different options, to control the heavy menstrual bleeding. So this is one trial that was published, a randomized trial looking at heavy menstrual bleeding. And again, it's a very subjective thing, but you have there are multiple different scoring systems that the GYN folks have. One of them is the pictorial bleeding assessment chart, so PBAC score, and anything greater than 100 is significant. So patients with a high PBAC score were randomized to receive intranasal DDAVP versus tranexamic acid. I don't know, are there chats? No, they're not. For 2 menstrual cycles. So they kept their charts before they started the treatment, before they were randomized, and then they were assigned to one or the other arm. Then they kept track of their PBAC scores, and then they were crossed over. And for 2 additional menstrual cycles, and again, keeping track of the PBAC score. Now, it turns out that both Stymate and tranexamic acid were effective. So compared to their baseline PBAC score, before they were randomized to the trial, both interventions resulted in a reduction in the score. But it was observed that tranexamic acid was slightly more effective. I'm not showing the statistics here in the interest of time, but a second randomized trial that was just concluded and presented at ASH, it was originated by Dr. Margaret Ragney from Pittsburgh, tested intravenous recombinant 1-Willebrand factor against tranexamic acid. And again, tranexamic acid seemed to come out ahead, slightly more effective. So perhaps this is why the ISTH folks recommended tranexamic acid, at least over desmopressin. Now the 1-Willebrand factor trial wasn't out when this guideline was published, but there's no harm in trying both, and you could stagger that. So another not infrequent situation is neuraxial anesthesia for labor and delivery. And the question here was, for women who require epidural, spinal, what level should one target? Should you go between 50 to 150 or greater than 150? Bottom line is they suggest between 50 and 150 over greater than 150. Again, low-level evidence. Now, I have to add here that I don't recall off the top of my head whether there were any anesthesiologists on this committee. And when we hematologists get together and come up with some guidelines, it's very important to include the people that are actually doing the procedure. When we were standardizing our anticoagulation practice in Mayo, we were pontificating that, well, you need to stop the drug on this date, on that date. And the anesthesiologist in our group and said, wait a minute, I'm doing the procedure, and this is what we need to do. So when it came to bleeding disorders for hemophilia, we were saying, oh, 80% should be good enough. The anesthesiologist in our group is saying, no, I want 100%. So you can see their perspective. But the bottom line here is the way I would take this message. When you're having a patient going into labor, it needs to be a multidisciplinary decision. In our institution, for every patient with a bleeding disorder that's going to have labor and delivery, we meet, we talk, we come to a consensus, and then we proceed. Now, they do say that selected situations, you might want a level that's pretty high, especially for postpartum hemorrhage. Antenatal monitoring of 1-Willebrand factor will inform the dosing at labor. So what we typically do is we monitor levels at every trimester And for the type 1 Willebrand, uniformly close to 100% of women, their levels will be normal when they're going into labor. So you don't need to give them a factor. And that's important, because if you give them factor and they already have normal levels, are you putting them at risk for thrombosis? So that's something to keep in mind. Now, the question of what's the trough level for von Willebrand factor that needs to be maintained, and anything greater than 50%, especially when the epidural is in place, and for 6 hours after removal. So those are the high-level guidelines. Now, this assumes you have access to quick turnaround time of assay results, and you're not just empirically dosing someone. Just recently, I saw a patient referred from another hemophilia center, and the director there said, you should treat them with von Willebrand factor concentrate twice daily, make sure the levels, X, Y, Z. So when we measured the patient's levels here, they were actually close to normal. And I think the patient was undergoing a thyroid surgery. We gave her only 1 dose of von Willebrand factor, and her post-op levels were sustained around 100%. So by doing daily levels, which I think costs less than infusing empirically twice daily, that was a very cost-effective approach. So having access to assays is very important. What about postpartum DVT prophylaxis? Everybody should get mechanical methods. Everybody should be encouraged to ambulate as early as possible. But if the patient cannot do that, or they've had a cesarean section, pharmacologic DVT prophylaxis definitely should be considered, and it needs to be individualized. So in the postpartum situation, a question that was raised was, what should we do with tranexamic acid? Now, the interesting historical fact about tranexamic acid is that it was actually introduced in Japan. I forget if it was management of heavy menstrual bleeding or postpartum. I think it was for management of postpartum hemorrhage. So that's the history of tranexamic acid. And what they do say is, in the postpartum period, it's better to use it over not using it in patients with type 1 or low von Willebrand factor levels during the postpartum period. And I have to say, I don't actually do that, but we do monitor levels very closely. And for those people where the levels come down after the placenta is delivered, we do individualize that decision, and we have occasionally used tranexamic acid. The recommendations must be based on the fact that there's a low risk of thrombosis. So let's move on to the different factor VIII von Willebrand factor products. You have your plasma-derived concentrates, where you have intermediate and high purity concentrates. Now, the intermediate purity, why is it called intermediate? It's not from the virucidal perspective, but the intermediate purity also contains factor VIII in addition to von Willebrand factor. So this product is very useful in the Normandy subtype of von Willebrand disease. Because remember, it's the von Willebrand factor that's dysfunctional. So you need to infuse a functional von Willebrand factor so that their factor VIII levels come up. For high purity, they have low or absent factor VIII, and each product has a different ratio, which I'll be showing you next. Now, is one product better than the other? If you look up the different products, there are actually so many out there, which is a challenge to know which one do I use. At least in the United States, different insurance providers have different products on their formulary, so they won't necessarily approve the product that we use at Mayo, so we have to actually get a product that they will pay for. So for management of minor and major bleeding, for prophylaxis of surgery, and routine prophylaxis, they're all equally effective. It's important to do pharmacokinetics to see how long each dose lasts. So if you're putting somebody on prophylaxis, so that you can judiciously dose them and not overdose them. For type 1 desmopressin responsive patients, as I mentioned, doing repeated dosing poses a risk for hyponatremia and seizures. So if you have to give them a pre-op dose of desmopressin and then follow that up with additional von Willebrand factor dosing, it's better to switch to a plasma-derived concentrate or a recombinant concentrate. For the non-responsive patients, all those with a short half-life on von Willebrand factor, again, you use von Willebrand factor concentrate. For subtypes 2 and for type 3 von Willebrand, of course, better to go with the von Willebrand factor concentrate. This slide simply shows you the von Willebrand factor histidine cofactor activity to factor 8 ratio. And you can see that what this particular product has the highest ratio, so probably the lowest factor 8 content. And then Humate has a very high ratio to factor 8. Then there's Willate, and then this is the recombinant product. It's got no factor 8 in it. So it's only got one Willebrand factor in it, which makes sense. It's a recombinant product. So the recombinant product is manufactured in cell lines. And the importance of that is there's no ADAMTS13 present in that cell line, but the plasma-derived product is derived from pooled plasma from, of course, hundreds of thousands of donors. So there's ADAMTS13 in it. And what does that mean? ADAMTS13 cleaves off the highest molecular weight multimers, and therefore they might not have the, depending on the product, they might not have all the hemostatically effective high molecular weight multimers. There's no evidence of thrombotic complications, and literally the studies have documented a very good efficacy rate overall. There are some trials. If you look on the clinicaltrials.gov website, there are some prophylaxis trials and pediatric trials that have been completed or are recruiting. And the recombinant product was only recently approved for prophylactic administration. In other words, for type 3 von Willebrand disease, prophylaxis, regular infusions. We were doing it anyway, but now it's FDA approved. So what does that mean? Insurance companies will actually uniformly pay for it. So here's some data on prophylaxis in von Willebrand disease patients. So Dr. Abshire was very forward-thinking back in 2013. Now, in this particular cohort study, most patients had type 3 von Willebrand. You can see it on the left at the bottom. There was a smattering of patients with other subtypes. They assessed multiple different bleeding symptoms, but I'll summarize it up here overall. Before enrollment onto the prophylaxis, the median annual bleeding rate, so that's what ABR stands for, annualized bleeding rate was 12. But when on prophylaxis, it dropped down to 3.6. The dosing was variable, and I think it was based on pharmacokinetics, but given between 17 to 60 units per kilogram, 2 or 3 times per week. So prophylaxis is effective in reducing the annualized bleeding rate. That's very important to keep in mind. Then, if you look at specific reduction in bleeding symptoms, epistaxis was reduced, GI bleeds was reduced, hemarthrosis. Now, with type 3 von Willebrand, they actually have a pretty high incidence of hemarthrosis, just like with severe hemophilia. With menorrhagia, there did not seem to be as much as, at least it wasn't statistically significant, although there was still a reduction. You can see up to 60% reduction, but compared to their baseline, it was not statistically significant. So Dr. Abshire conducted a separate trial where they dose escalated von Willebrand factor. Because the question here is, you could start with one dose, but then how do you escalate? So you've done the baseline annualized bleeding rate, and we ask our patients to keep a log of their bleeding, because any intervention you do, you want to make sure that you're having an effect. So what he did was they started with 50 units per kilo, but if that wasn't effective, they went up a level. This is once a week, twice a week, 3 times a week. And then you can, even on the hot, one patient required 75 units per kilo every other day. So that was a higher treatment level. And following this, once they were stabilized on their required individualized dosing, the annualized bleeding rate dropped from 25 all the way down to 4. It didn't drop to 0, but 4. And so based on this very limited data, the ISTH recommended using long-term prophylaxis in patients with severe bleeding disorders rather than no prophylaxis. That's the bottom line. It's expensive, certainly not cheap. What about surgery? Because a lot of patients, our patients are aging, and median life expectancy was pretty low with bleeding disorders in the 60s and 70s. And now, with contemporary management, patients are living into the older age. So they require knee replacements, hip replacements, general surgery. They were each country, like Dr. Nichols from Mayo Clinic, led the US guidelines in 2008. But then the Italians, the Dutch, all had their own guidelines. Now, the goal of showing this is not necessarily for you to look at each cell, but the questions addressed are: what's the loading dose? What's the maintenance dose? What do you monitor it? And what's your therapeutic goal? So each had their own guideline, but not every guideline gave specifics. That was for major surgery, and this is for major bleeding. So similarly, there were different opinions on how to approach this. So the ISTH committee, ASH, ISTH and World Federation Committee got together and said, okay, let's come up with some consensus. And this is important. So for those undergoing major surgery, should the factor VIII or the von Willebrand factor be kept above 50%? Now, why the distinct, because this is von Willebrand disease, why factor VIII? So Dr. Manucci from Italy is a strong believer that von Willebrand factor is really not that important. And it's really factor VIII that's more important to maintain hemostasis. But of course, it's very hard to come up with the evidence for that. So the panel suggested that both should be kept above 50% for at least 3 days after surgery. You can look at the level of evidence. This is 4A. The 4B was they suggested against using only factor VIII as the target. So again, they're saying use both. Trough levels should be kept above 50%, but the specific target should be individualized based on the patient, procedure, bleeding history. And I think this is very important. You might not have these assays in your laboratory. So really, for a cost-effective approach here, you really should, these surgeries and factor replacement really should be done in an institution that has access and rapid turnaround to the assays. The duration of replacement will vary with the type of surgery. So there's no good evidence base to tell you, treat for 5 days, treat for 7 days. It really depends. If you have neurosurgery, I'd probably overdo it. But if you have minor procedure, you probably won't overdo it. Which product do you use? I mean, if this graph basically shows you the half-life of the recombinant product post-infusion in red versus the plasma-derived product. And the bottom line is the plasma-derived product has a shorter half-life than the recombinant product. For years, we've been using the plasma-derived product. And when the recombinant product came available on the market, we had the drug reps come to us and say, would you get it on formulary? And I said, for 25 years, we've been using plasma-derived. Why would I go to a more expensive product when the plasma-derived, I've never had a problem with it. But I went ahead and got it on formulary, and we have to go through a P&T committee to get it on formulary. And I sheepishly approached them. I said, look, maybe we should look at it, but I'm not sure we should get it on. So if you refuse it, I'm fine with that. Actually, the P&T committee said, well, it's got a longer half-life. So it may be more expensive, but you'll use less of it. So overall, there'll be a savings. And I thought, wow, that's a good way to think about it. So we got it on formulary. And to be honest, I've been very happy with the recombinant product because of the half-life issues. The challenge in our practice in Mayo is we're rural and most of our patients come from many miles away. So when they have their surgery, we use the recombinant product, we do pharmacokinetics, and when they go home, I'm able to, based on pharmacokinetics, suggest a dose and a schedule. And with the recombinant product, with the longer half-life, I'm certainly infusing less of it. So that's a big advantage to this product. This is showing data on the half-life of the one recombinant product with the different assays. So the ristocetin cofactor is in green triangles. You get a nice elevation. and then a slow decline coming down to baseline over 72 hours. In red is the antigen, which similarly goes up and gradually comes down. Now, I'll point out the interesting fact about factor VIII. So these are patients who have a low factor VIII because of their von Willebrand factor. So their baseline, and these are type 3 patients, their baseline factor VIII is quite low. So when you give them recombinant product, remember there's no factor VIII in the product. It takes about 6 to 12 hours for the factor VIII to come up to, above 60%, which is considered, the minimum you need for surgery. And so if you have somebody with type 3 von Willebrand, they have almost a factor VIII that's severely reduced, and you're going to do surgery on them, it's better to start the dosing of the recombinant product, if that's what you're going to use, the night before. Because giving to them just before surgery, which was what we do for most of our other patients, they will not have a good rise in the factor VIII for 6 to 12 hours. Or if you're going to infuse them the morning of surgery, give them the recombinant product, but also give them factor VIII, because I think factor VIII is very important for the immediate hemostasis as well. So some additional questions. For minor procedures, should you raise von Willebrand above 50%? Should you use antifibrinolytic agents alone, or should you do both? They do suggest raising baseline levels above 50% with either desmopressin or von Willebrand factor and adding tranexamic acid. That's a good guideline, but I'm not sure I would necessarily do that. For instance, if it's a excision of a mole, or if it's a dental extraction, I think you can get by with tranexamic acid alone. Typically, I start that the night before. Now, for certain patients, though, however, they say go with tranexamic acid alone in these situations. If you have a type 1 von Willebrand with levels greater than 30%, if you have mild bleeding phenotype or minor mucosal procedures. So in those situations, you can certainly get by with tranexamic acid alone. I would caution that you avoid using tranexamic acid in genitourinary procedures. So if a patient has hematuria, especially if they have hematuria, kidney stone, and they're bleeding, giving them tranexamic acid does put them at risk for developing renal stones. So that's a risk to keep in mind. Renal clots. So I brought up the risk of thrombosis a couple of times with DDAVP and von Willebrand factor concentrate. So this was a meta-analysis of studies, 361 patients, 11 studies. Of over 8,000 infusions, there were only 2 events for deep vein thrombosis and 5 of superficial vein thrombosis. Now, so again, if you judiciously dose von Willebrand factor, you should not experience thrombosis complications. Coming to some unique features of von Willebrand disease, gastrointestinal hemorrhage is very common. And in over 4,500 patients in one series, of whom most had congenital von Willebrand disease, type 3 von Willebrand, there was a 4.5 prevalence of GI hemorrhage, and smaller with type 2. And in this series, nobody with type 1. But with acquired von Willebrand syndrome, there's actually, it's very common to get GI hemorrhage. And the mechanism here, the pathophysiology here is that if you lose your high molecular weight multimers, and the high molecular weight multimers have an anti-angiogenic effect, that somehow stimulates GI hemorrhage. And this association was first described in the Hades syndrome, where patients with aortic valve stenosis, due to the high shear, they lose their high molecular weight multimers of von Willebrand factor, and they develop GI hemorrhage. You fix the aortic valve, you fix the GI hemorrhage. So we talked about GI. I shared some data with you on prophylaxis, but the management of GI bleeding in von Willebrand in the prophylaxis trials is shown here. You do improve the GI bleeding by 50% or so, and you certainly improve hemarthrosis in patients with severe bleeding disorders. Now, in another study by Pevandi, they did not observe a reduction in GI bleeds in their group of patients. So there is some discrepancy in the different trials. The potential explanation is that what they used before the recombinant product became available, what they were using is plasma-derived concentrates, which do not have that, and they don't consistently have the high molecular multimers. And maybe that's the reason why there wasn't a consistent improvement in GI bleeds. There are trials with the recombinant factor concentrate, and we'll see if that makes a difference. Now, I'm sure that in your practices, you do come across patients with recurrent GI bleeds, and what are the options? Because 1 Willebrand factor replacement is not cheap. Are there other drugs that we can use? So for those that are interested, the Biguzzi review article, Blood 2020, is a very good resource. And they summarize all the case reports and series using danazol, thalidomide, octreotide, and lenalidomide. I myself have used danazol quite a bit in case series and published them, and that has been effective, but it's hepatotoxic, so you have to be very careful. And then there are case series or case reports of the other agents. I'm going to conclude in the next few slides with acquired von Willebrand syndrome. It's rare, but perhaps it's rare is because we don't think about it and we don't test for it. Clinical manifestations are same as with congenital, except it's patients present in adulthood with new onset of bleeding when their previous hemostatic challenges have been completely unremarkable. The true population prevalence is not known. Of course, the diagnosis does rely on the same assays. And it's important to note that acquired von Willebrand syndrome is seldom an idiopathic event. And it's most of the time associated with one of the disorders I list on this table. Most commonly monoclonal protein disorders. Second most commonly cardiovascular disorders, so cardiac valvular stenosis, hypertrophic obstructive cardiomyopathy, myeloproliferative disorders, and then much less frequently you have the other conditions listed here, and then there are like case reports of others. The ISTH has a registry on their website, and so one of the points of this table is that if you diagnose acquired von Willebrand syndrome, it's important to look for one of these underlying bleeding disorders. And the pathogenesis will depend on the underlying disease. So it could be von Willebrand factor clearance by the complex with either specific or non-specific antibodies, or even monoclonal proteins. There's cases where malignant cells have been shown to express the glycoprotein 1b9 receptor. So they suck von Willebrand factor out of the circulation. And then when you have conditions of high shear stress, such as aortic valve stenosis, you lose the high molecular multimers. So increased proteolysis is the mechanism. And if you understand the mechanism, you would, number one, find the underlying disease. And if you treat the underlying disease, most of the time, the underlying von Willebrand factor responds. I'll share a couple of slides on monoclonal protein associated acquired von Willebrand syndrome. And if you look at the IgG monoclonal protein associated syndromes, and you replace them with either DDAVP or von Willebrand factor concentrate. So in this slide, these were 8 patients, I think, but and the three different assays. You can see after infusion of the von Willebrand factor concentrate from baseline, they had a very nice response. 1 hour later, they're down, and 4 hours later, they're down to their baseline. So the monoclonal protein clears the von Willebrand factor from the circulation. Is there an intervention that you can do to prevent this from happening? So it turns out with IgG monoclonal protein associated acquired von Willebrand syndrome, if you infuse gamma globulin and at a 1 gram per kilo given on 2 days, without any von Willebrand factor replacement, their levels go up very nicely and they're sustained. Now, in this case, they were sustained for up to 8 days. We have patients in our practice where they only need 1 infusion every 3 weeks. So the responses are variable, the duration of response is variable, but IgG monoclonal protein associated acquired von Willebrand syndrome, think about IVIG. I don't know if it's cheaper or more expensive than von Willebrand factor replacement, but this certainly will increase the half-life. I do want to point out what's very important is if you have an IgM monoclonal protein, they do not respond. So I still end up doing a trial of IVIG, but I've had 2 patients who responded, but most patients don't respond. So this is my last slide, and I think what we've been able to do is take a tour of the updates in the approach to diagnosis and management of congenital von Willebrand disease, and we touched a little bit on acquired von Willebrand syndrome. And so I will stop here, and I thank you for your attention.
Thank you, Professor Rajiv, for this beautiful journey. Enjoyed it. We have now our colleagues, and we already have a raised hand sign. We'll start with the questions. Dr. Rucha.
Yes. Sir, thank you so much for this very informative lecture. I have to say it was really nice. Thank you for giving this lecture to us. So my question is, in India, we see a low prevalence of type 1 VWD and a high prevalence of type 3, opposite to Western literature. This is attributed to the low awareness and underdiagnosis. But if you go to see, we have got 17 to 18% of type 1 VWD, and we are screening women with menorrhagia. Even CMC is doing it. We haven't still found an increase in the prevalence in type 1 VWD. So I have 2 questions. Type 1 being a dominant inheritance and type 3 being recessive, can this prevalence be attributed more towards the high consanguinity which occurs in India? Or the second part is, if we are yet missing and we have checked and we are checking in women with menorrhagia, are there any other symptoms or where other groups where we should be testing VWF antigen, the Ricoff, and the platelet aggregation?
Okay, so if I understand the first question right, you're asking if it could be an assay problem.
No.
For the type 1.
Type 1, yeah. Why are we missing it?
Type 1 is notoriously very difficult to diagnose. And as I said, there are multiple variables that affect levels. So it also depends on when you're testing. There's weak data looking at the menstrual cycle. Other patients in stress, the levels go up. Children particularly, you know, they're screaming, shouting, and you're trying to stick a needle in their arm, levels go up. But you raise a very interesting question as to, still, despite all of that, you still should see a prevalence, because that is supposed to be the most common, right?
Yes.
You know, there may be founder effect mutations. It's very possible that among the white population, there are other more common mutations which leads to the type 1. And I think there's more being understood about the von Willebrand factor and other non-genetic factors that affect it and genetic factors. So is it clearance? Is there a receptor for von Willebrand factor clearance mutated, or is it? I think I'm speculating here, so I think you get that. So I'm not sure I have a good answer to that question. It's a good one. What was your second question on the type 3 or?
No, the type 1 only. If we are missing a population, like we are screening menorrhagia, meaning women with menorrhagia, is there any other group which you think we are missing out? Like it should be screened for von Willebrand?
Yeah, good question. Now, I think you going through that questionnaire listed on that bleeding assessment tool, that's really the only tool available. And you focus in, personally, although there's a reference range, you also look at the family history as well, right?
Yeah.
And if there's a family history, you definitely do the testing.
Yes.
But I think what you're saying is, in spite of testing, you're not necessarily diagnosing them, right?
Yeah.
So here's the question. If you have bleeding symptoms, von Willebrand testing is normal. Do they have other bleeding disorders? Now, keep in mind, there are some literature for like Dr. Kathy Hayward from Canada. Her lab's like a very comprehensive lab. They do a lot of platelet function testing. She feels platelet function disorders are perhaps more common or equally common to von Willebrand disease. Now, if you don't have, not every lab has the technology to do platelet function, so maybe we're missing those patients. You see what I mean?
Yeah, we do platelet aggregation, and we too believe in that. So we are doing NGS in all the wherever the patients get a platelet aggregation which is abnormal. So yes, we do agree with her that, you know, there are many being missed that way. But yeah, thank you.
Thank you.
Lovely questions and good discussion, Dr. Ankit.
Yeah, thank you, sir. Thank you, Dr. Pruthi, for that wonderful and comprehensive overview. So my question is in continuation with the last conversation. So do you feel that doing genetic testing for mutation analysis in von Willebrand factor gene will replace in future the need of doing multiple tests for hemostasis, and what are the caveat and hurdles in that?
That's an excellent question. I think the bottom line is, so the lab assays that I talked about, I'm going to categorize them as phenotypic tests, right?
Right.
I don't think you'll ever get rid of phenotypic tests. You need them for your daily management.
Right.
Now, I've always had a bias against von Willebrand factor genetic testing. And even though my lab offers it, and you know, we get actually of the NGS test we offer, that's the highest number, which I understand because of, you know, the previous question is you have somebody with bleeding symptoms, the von Willebrand factor levels don't give you much answers. Let's do von Willebrand factor genetic testing. Maybe we'll find a mutation. So I'm giving you a long-winded answer, and I'll tell you my von Willebrand factor is a highly polymorphic gene. And I don't understand why it's so polymorphic. And there are so many variants that we're finding that, first of all, haven't been described in the literature. So how do you assign pathogenicity to that variant and tell that client or the patient, this is what's causing your disease? So that's
that was the second question. So is there any way to connect genetic versus phenotypic severity of the disease? So
yeah, absolutely. So I think for the type 3 von Willebrand disease, that would be very important, because I would envision in the future when a child is born and there's a family history of a bleeding disorder. Literally, right now you do newborn screenings, right? I think at some point they'll be doing newborn screening, genotyping everybody for different diseases. The type 3 von Willebrand is the most severe. And there are definitely mutations, so nonsense mutations, premature termination, deletions that are highly predictive of phenotype. So that's the one group I find useful. So I was at a meeting and they were talking about, well, it's a severe disease, you'll do prenatal testing, et cetera, et cetera. So I asked one of my junior colleagues to look at all our type 3 von Willebrand patients and go into their birth history and see how many of them actually had intracranial hemorrhage at birth. 0. So would you subject that precious pregnancy to a prenatal test when it's not going to affect the outcome of the labor and delivery? So the practical application of prenatal testing is, gosh, do you really want to do it? See what I mean? But to answer your question, I think there is a role to distinguish type 2A and 2B, because if you have type 2B, and again, the phenotypic tests may not be valuable. We know that type 2B patients have thrombocytopenia, type 2A don't. But then Dr. Federici described a group of type 2B patients with normal platelet counts. So he said, okay, that theory goes out the window. The Ripper test is not available everywhere. So I think in that unique, you can focus the testing on a region where you can distinguish 2A and 2B. And the reason is because you would not use DDAVP for the 2B. So that's the practical application that at least in my view.
Right, sir. And one more question is regarding von Willebrand disease in pregnancy. So in pregnancy, the level of von Willebrand factor physiologically increases. But in case of type 2N or type 3, how would you manage bleeding symptoms, or would you give prophylactic?
Yeah.
Because in those patients, we may not expect a very high increase.
Right. For the type 3, we definitely put them on. it depends also on the bleeding phenotype. Now, some of our patients are already on prophylaxis, so we would continue that. For those that aren't, and there are patients not on prophylaxis, towards the, we monitor them closely towards second, third trimester, then we actually put them on prophylaxis prior to labor and delivery. For the 2N though, I'm trying to think, their levels go up, right? The von Willebrand factor levels go up. So factor VIII also goes up, even though there's a binding defect.
Okay.
But around the time of labor and delivery, we do measure levels. And if their 8 levels are not acceptable, we do give them a dose right at that time.
Okay.
It's a balance between hemostasis and reducing the risk of thrombosis. So really you have to be very careful and balance it out.
Right. And last question regarding the same thing. Once the parturition is occurred and the postpartum period, when do you check for the levels again to see whether they have reached baseline and if there is a risk of postpartum hemorrhage?
Yeah.
In the same patient?
So postpartum hemorrhage is very serious, and I think it's life-threatening. It's one of the, I think apart from thrombosis, postpartum hemorrhage is really a big problem. So we overdo it. I'll admit that. We're checking levels every week postpartum, and if the levels fall below 60 to 70%, we treat them. Now, most of my patients, when I see them, and if they're having some sort of a minor procedure and I'm using von Willebrand factor concentrate, I just do kinetics on them. So I know in future, I can use that information. So for women, that's proved very useful. We give them the factor at the labor and delivery, and then we monitor them. They go back to their home communities. I already know their pharmacokinetics. Then I can just have a home health nurse go in and infuse them empirically sometimes. And we usually do that for 3 to 4 weeks afterwards.
Right. Thank you so much for patiently explaining everything.
Thank you, Ankit. Dr. Chandrakala.
Thank you, sir, for wonderful lecture. The same, again, what Dr. Ankit told. We actually have at least 3 to 4 patients per year with patient delivery. And we have never given prophylaxis for these patients. But last 2 pregnancies, we had a patient who has a retroplacental clot. So in those patients, prophylaxis, how much to give prophylaxis? And we can't monitor VWF because it's like it takes some time to get the VWF levels, antigen levels. So we monitor with factor VIII. Even in surgery, we monitor with factor VIII. So how much factor VIII usually we may aim at, how much factor VIII we should aim in these patients? Yeah. And these 2 patients also had a postpartum hemorrhage, almost about 6 weeks postpartum. They had bled heavily, delayed postpartum hemorrhage they had come with actually. So these were very problematic cases we had. So how much usually dose we give?
That's a very good question. And currently we're lucky in our institution, we have the assays, but back when I first joined the practice, we did not have access to these assays. All we had was factor VIII. So like you, I was using factor VIII to monitor these patients. So I think you can still do it because I never had any hemorrhagic problems with that. We would use the same target for factor VIII, greater than 50%. But now, if I understand you right, the patient with the retroplacental clot was not on prophylaxis before the labor and delivery. But at what gestational age did the clot form? Do you know? When did the clot form during pregnancy?
It was around 24 weeks of gestation. She had come the road. She actually diagnosed as a VWD when she had a retroplacental clot. She had a parvaginal bleeding and she had a retroplacental clot, and then she was diagnosed as a VWD.
Oh boy. Okay. Yeah, I think so. So it's of course a hematoma is what I would call it. So I wouldn't be afraid to replace von Willebrand factor in her, but I would target above 50% through the remainder of her pregnancy and then postpartum. So the 6 weeks postpartum bleed is concerning, though. Have you used? You have tranexamic acid or Amicar?
Yes.
Is that something you could use?
We have used her. Actually, we have used for 4 weeks, and we stopped for about 2 weeks, and then she came with PPH, and it was requiring a blood transfusion. The hemoglobin dropped to 3 grams. So because they had to travel for a long time, and they came with very low hemoglobin. We have used for actually 4 weeks. Till 4 weeks, we give tranexamic acid. So usually not a very high dose because of balancing that whether they develop a clot. So maybe like instead of high dose of 25, we give 10 milligram per kg 3 times a day. That's what we give it for these patients.
Okay. Okay. Yeah. Yeah, I would have done the same, 3 to 4 weeks, but I guess it's unfortunate she bled at 6 weeks. It's really hard to predict, isn't it?
Yeah. So the other question is, we have a patient now, like 2-3 patients with there are inhibitors to VWF, and she had an inhibitor to VWF along with the pseudotumor of the jaw. So that was a very nightmare to manage this girl. Actually, she had a reaction like reaction like in the form of rash, and then not responding to VWF, and then she found to have inhibitors, and she had a pseudotumor. So in that time, she's a young girl. She was bleeding from the oral cavity and along with the pseudotumor of the jaw. So in those patients, what do you use in those patients?
Was this a type 3 von Willebrand?
Yeah, type 3. Type 3.
Wow, that is complicated. So there are case reports, and this actually I should say is one case report, and then I have one patient with type 3 and Ehlers-Danlos. So just prophylactic von Willebrand factor doesn't work. I actually put my patient on emicizumab, so Hemlibra, and you know the case report came from University of Michigan, Dr. Steve Pipe. Using that case report, I could justify the insurance company to pay for my patient's emicizumab, and her bleeding frequency markedly improved. Now, I have to say that I've been looking for inhibitors to von Willebrand factor for many years. I haven't found one yet. So this is pretty interesting that you have a case. I think, did you do kinetics on the von Willebrand factor once you infuse it? Because you might have an inhibitor in the lab, but it also affected the half-life?
Yes, sir. It also affected the half-life. She did not recover actually. The factor VIII levels was very low. Even after, and then we mixed the plasma of the patient with the normal, and then we found that she was inhibiting. And we had to do surgery with under Nova-7 and put them in emicizumab prophylaxis. So she is on emicizumab.
So she is on emicizumab?
Yeah.
Okay, perfect. That's what I was going to say. I think it's factor VIII is more important, and the patient's behaving like a severe hemophilia. So there you go.
Thank you,
that helped reduce the bleeding, right? You're on mute. Sorry.
Muted. Chandrakala, you got muted. Repeat.
Yeah, sorry, sir. Yeah. She helped a lot actually, because post-surgery, we had to do surgery because the teeth was coming out, excavation was there. She had difficulty in swallowing. Nova-7 was given during surgery, and after day 3, because we could not manage so much of Nova-7, we gave her emicizumab, and the bleeding came down, and we gave her actually 3 months of post-mortem, and we have reported that case in the Hemophilia Journal actually. So she had a very good response to emicizumab.
Good.
Thank you, sir.
Thank you. Dr. Radhika.
Thank you, sir. Thank you for the comprehensive presentation. Sir, as you have clearly depicted in your presentation, prophylaxis is a recommendation now, but it's not a feasible option in a country like ours. In young girls presenting with menorrhagia, is it an acceptable option to use cyclical prophylaxis? That is, give von Willebrand factor only during the menstrual cycle. The cyclical prophylaxis, that week of menstrual cycle, in the next month, because I do not want to unnecessarily alter her cycle. She's a young girl, alter the cycle with hormonal therapy and all. Is that an acceptable one?
Yeah, absolutely. I think.
Like that.
Yeah, I think that's a very good way to do it. I think your screen is frozen. Are you still connected with us? Okay. I think you were breaking up intermittently. So the question I think you're asking is it acceptable to give von Willebrand factor replacement during the cycles and not in between? I think that's definitely an acceptable way to do it. In fact, the way we use tranexamic acid is for the first 2 to 3 days of their menstrual cycle, we put patients on tranexamic acid. Or if we're using desmopressin, day 1 and day 3 or 4 of their cycle. So I think it's very reasonable to do the recombinant one or von Willebrand factor on the first day of the cycle. In fact, the randomized trials that we just concluded, the way the strategy was, on day 1 of their cycle, you would infuse the factor. And if they needed a second dose on day 2, we'd give it. Now that, compared to their baseline, that did improve their PBAC scores quite significantly. The comparison between tranexamic acid was a little better. So yes.
Had it been type 3 von Willebrand, then probably tranexamic acid may not really work out, right, sir? If it were type 3 von Willebrand disease.
Actually, it should. So the mechanism of antifibrinolytics is it interferes with plasmin degradation of the fibrin clot. So it's nothing to do with von Willebrand factor. So yes, it should work.
Okay, thank you, Dr. Chandrakala.
Second question. You have clear. May I ask my second question, sir?
You can, but your voice is breaking. Can you put off your video? Maybe you will be more clear.
Yeah, sure. I'll wait for the next person and then raise my question.
All right. Chandrakala.
Yes, sir. Yes, sir. So regarding the same thing, actually menorrhagia, and we also see patients with hemorrhagic ovarian cyst and coming with hemoperitoneum, and sometimes the patient comes like a shock also. So in those patients, should we put them on like oral contraceptive pills? For how long we should keep them on oral contraceptive? That is like young girls, they don't want to take for a long time. Prevent the ovarian hemorrhagic cyst, we keep them on OC pills till they get married, until they plan pregnancy. So is it the same practice you do? Should be, because we can't give prophylaxis, even like 1 week of prophylaxis, because if you stop them, they bleed anytime. So it's not even like every month they will have cycles. They bleed in between the cycles also.
Yeah. So the duration of oral contraceptives, right? Is that what you're wondering? Yeah. I have to admit, I'm not very experienced in that aspect. We work with our gynecology colleagues. I have to say, I'm not. Is this a severe type 3 von Willebrand that you?
Yes, severe type 3, and they are the one who's going to have this ovarian hemorrhagic cyst and hemoperitoneum actually. Mid-cycle pain and yeah.
I don't think there's any good data to tell you how long to do the OCP, but you're right. I suppose in theory what I would do, but I'd work with my gynecology colleagues, of course, is to keep them on it until things resolve. And if I think young women who suddenly see a marked improvement with the oral contraceptives, they want to stay on it. Of course, before they have children, you'll have to stop it, and then you do risk bleeding, of course.
Thank you. We'll take one question from the audience. Dr. Christopher wants to know, you actually said that you've not seen inhibitors in these patients, but the question is there a risk of developing inhibitors in von Willebrand disease apart from type 3? And how would you address those who develop the inhibitors?
Yeah, it's a good question. As I said, even in my type 3 patients, I've never seen an inhibitor develop, certainly not in type 1 or type 2. So I've never seen that develop. If you were to see that, even the type 3, I think you would look at alternative ways of managing the bleeding. Now, I have to say, emicizumab is the only drug available right now, and it's for hemophilia, but still, it might work in other. It has worked for my one patient with type 3 von Willebrand. But there are other targeted drugs in clinical trials, and you may have read about drugs like concizumab. It interferes with tissue factor pathway inhibitor. That's going to be an amazing drug. It works in hemophilia A and B, and why wouldn't it work in von Willebrand disease? But it would remain to be seen. And then you have the antithrombin, small interfering RNA that lowers your antithrombin level. At least in hemophilia, it markedly reduces the annualized bleeding rate. So I think going forward, there's going to be other options we could consider for this situation. For example, if you develop an inhibitor.
Thank you. Ankit?
Yeah, thank you, sir. So my question is regarding the patients who have frequent GI bleeding. So typical patient will be a patient who is more likely than not HCV positive with very difficult venous access and requiring multiple units of cryoprecipitate and PCV, maybe every 15 to 1 month period. And because we use cryoprecipitate due to non-availability of the von Willebrand factor concentrate, My question is regarding that, whether there is any correlation between angiodysplasia with use of more cryoprecipitate as compared to factor concentrate, and whether there is any role of hepatitis C or chronic infection.
That's an interesting question. I'm not aware of the hepatitis C correlation, but the GI bleed and von Willebrand disease, it's very well correlated. In my experience, von Willebrand factor replacement has never worked. Putting them on prophylaxis with an expensive drug, it's just not worked. So what we do is we try to investigate them, and if there's one lesion, you can ablate that. But more often they have multiple lesions, stomach, colon. And so I've tended to go, so one of the slides I showed was the Buguzzi paper, and they summarize the different interventions. Anecdotally, I've gone with danazol most of the time. And if there's no contraindication, I've had success with that for sure. One patient with congenital factor V deficiency, I'm not sure why he developed recurrent GI bleeds, but thalidomide worked in him. You have to be careful with thalidomide, of course, and with the usual precautions. But then there's also these other case reports in the literature of lenalidomide and those sort of drugs. So I would perhaps avoid an expensive intervention that, at least in my experience, hasn't worked, and go with something that's oral, tolerated, and see if that works.
Right, sir. Thank you. Thank you, sir.
Akansha?
Hello, sir. Thank you so much for the very educative talk. So my question is basically regarding acquired von Willebrand syndrome. So sometimes, in patients with polycythemia vera, even at lower platelet counts, some of them do have a higher bleeding tendency. So I'd like to ask you, what is the cause of this, and does it also depend on the JAK2 mutation status in these patients? And in such a scenario, how does that change our management for these patients?
Yeah, it's a good question. So polycythemia vera, acquired von Willebrand syndrome, where the platelet count is not that high, correct? Is that what you're describing?
Yes, sir.
I would still try to lower the hematocrit. What I don't know is it the hematocrit that affects the acquired von Willebrand, or is it only the platelets? Recently, I had a patient with polycythemia, very high hematocrit, and a platelet count of over 1 million. And we struggled with that patient, but we did therapeutic phlebotomy and hydria to get both down. And that seemed to result in an improvement in the von Willebrand factor level. So it depends on what the level of the platelet count is, because I guess I would do one intervention at a time. Is the patient bleeding frequently, or?
She had a few episodes of persistent bleeding after phlebotomy. So that there was a concern from the transfusion medicine team, because they are performing the phlebotomy. So, but other than that, she has not had any other.
Okay, so no other systemic bleeding, but just at the site of where they took the blood, right?
Yes. And she initially, when she came to me, she came with the history of recurrent miscarriages, and she had not been worked up for. She had a persistent higher platelet, but no further workup was done for her. And then she was eventually diagnosed to have a polycythemia vera with a JAK2 mutation positivity.
Okay. Yeah, I don't think the JAK2 mutation affects the risk of having acquired von Willebrand syndrome. So if the erythrocytosis is a major problem, I would be aggressive and lower that down to the target, which is usually 40 to 45%, and see if that helps her bleeding symptoms. Otherwise, have you started her on hydria, or?
Yeah, I did start her on hydria, and she basically for ecospin I had to stop because then she was having the bleeding tendency. So just I've kept her on hydria because the TLC I was basically concerned with the higher TLC counts. Although she has not had any history of thrombosis, but yeah, that's what.
What hematocrit did you reach at then?
Actually, when she came to me, she had a hematocrit of, I've just seen her 2 to 3 weeks back. So it was at 52. And now she has reduced to around 49, 48.
Okay. Okay, and that's all I would think you could do is lower the hematocrit, control the platelets, and see how she responds. I don't think there's any other medicine that you can use here.
Yeah, exactly. Yes. Okay. And we should be cautious with using the aspirin. So I think just giving.
Yeah, if she already has bleeding symptoms, I guess I wouldn't use aspirin.
Yeah. Okay. Thank you.
Okay, thank you. One last question from Dr. Radhika, if we can hear you.
Yes, sir.
Yeah, go ahead.
Yeah, sure. Sir, in your presentation, you have said, right, mild type 1 Willebrand disease, some patients with aging, the levels normalize. In type 1 VWD, some patients with aging, the levels normalize. So can we nullify their disease as VWD now? They were VWD once upon a time, but now they are like any other normal person?
That's a really good question. And I think that the guidelines, I took that slide out because it didn't make sense to me. So the guidelines did address that question. They were diagnosed with von Willebrand, now levels are normal. Should you remove the diagnosis or should you reconsider the diagnosis? And their recommendation was reconsider the diagnosis. And I'm asking myself, well, what does that mean? So practically speaking, there's two aspects. It's possible they had a low von Willebrand factor because they're blood group O. So I'll pay attention to that. And when now they're normal, I'd say, look, I don't think you have von Willebrand. And most of these patients don't have a bleeding history, right? Or they had minimal bleeding and somebody did the test and 20 years ago, the assays weren't that good. So they're given the diagnosis. Now, the other part of this, I have several patients like this. They come to me for a procedure and they're so rigid. I want my DDAVP before the procedure because I've always had DDAVP and I've never bled. So, if it's a minor procedure, I try to convince them it's a dental extraction. I said, look, let's just try that without DDAVP. We can go with tranexamic acid if you're comfortable or nothing. And so I have variable response. Some people are willing to try and some just, they want their DDAVP. Okay, we'll do it. In the end, a lot of it is patient satisfaction. But if I draw the line at them saying, I want my von Willebrand factor concentrate, I say, no, that's too expensive. And that perhaps puts you at a high risk for thrombosis. So I think it's very individualized and really patient dependent. So I try to understand what the patient's values and preferences are. There's a NIH study looking at that now, where they're collecting patients from all across the country. The main question is, what was their bleeding score when the diagnosis was made? What's the bleeding score now? And there's really no good data to tell you that. So that's a long-winded way of saying, it depends on the patient.
That patient needs to be taken up for a major surgery.
And what's the current levels now?
I don't have a patient like that. I don't have any patient who has normalized. And just that patient has to be taken up for major surgery. Levels are above 50.
If it's major surgery, so again, it's individualized, minor versus major, what the levels are. For major surgery, I lean towards giving them one dose of DDAVP.
So thank you very much, Dr. Rajiv Pruthi. That was marathon, 2 hours lecture, discussion. We enjoyed it. You have really created a lot of experts in von Willebrand disease all around the world at the end of this session. A lot of people will have improved care of their patients. This learning was extraordinary. I'm extremely grateful to you. On behalf of everybody, I thank you. And of course, thanks to all the participants, thanks to our sponsors, and thanks to the event management team. Thank you so much, sir.
Thank you for the privilege. Have a good weekend.
Bye.
Bye-bye.
you.